and we'll get started. So just for everyone to know, we are going to have a discussion with Professor Reuven Dar. After the discussion, we have a lot of questions to get through, so I really hope that we get through everything. We will then have just a short little bit of time towards the end to allow you the opportunity to ask Professor Reuven any questions, or if you have any comments for Professor Reuven or myself. So if I may ask that you don't raise your hand unless there's like a technical issue, you can't hear me or you can't see me or something's happened with the recording. But in the meantime, throughout the session, you're welcome to add your questions or your comments in the chat. And then at the end, because I can't multitask, I need to focus on one thing at a time. At the end, I'll go through all the comments and questions and address them to Professor Reuven. Okay, and there's a little reaction bar at the bottom, so you're welcome to show your reactions as we proceed. So without further ado, we're really pleased to be joined today by Professor Reuven Dar, who is not only a leading researcher and psychologist in the OCD field, but also a valued member of our clinical and scientific advisory board here at Helping Minds, which is the creator of Stop OCD, and who also serves on the clinical advisory board at the IOCDF. Reuven has spent decades studying obsessive-compulsive symptoms and how they show up in real life, particularly the idea that OCD can involve difficulty accessing internal states, leading people to rely on external proxies for certainty or relief. And don't worry, we'll hear a little bit more about that a little bit later. So we're excited to begin a series of conversations with Reuven, starting with a broader discussion of OCD and getting to know him a little bit more. And how it's commonly understood, what's often misunderstood, and how our thinking about it continues to evolve. Reuven, thank you so much for being here with us today.
Glad to be here.
Great, it's an absolute pleasure. So for those who may not be familiar with you and your work, could you just share a little bit about your background and what first drew you to OCD research and clinical practice?
Okay, so I did my PhD in clinical psychology in Wisconsin, in Madison, Wisconsin, in the US. I did actually all my training there, including my internship and then postdoctorate. And when I was a student and desperately needed money, I joined the psychiatry department. They had a very old-fashioned behavioral therapy clinic where the people like us who were not yet psychologists but training to be psychologists were doing classical behavior therapy. So that was, exposure with people who had phobias and exposure and response prevention with people with OCD. And that's the first time I encountered people with OCD and with anxiety disorders. And later on, actually quite a bit later on, I actually started doing research on OCD. It was already when I wrote a little bit about more clinical stuff when I was still a student and shortly after I received my position in Tel Aviv. But real research on OCD took a while before it started. So the first encounter with OCD was in this clinic, with behavioral therapy clinic.
I'm just reflecting back in your internship, and you saying that you really started doing some research then. That's incredibly ambitious. I know how tough an internship is, and you still then found the time to write some research. That's quite amazing.
It was easier for me because I did the internship in the same place that I already was familiar with the clinic. I had connections with the psychiatrist there who led the clinic was Professor John Grice, still around and still doing research.
Yeah.
So it was smooth, relatively speaking, to start doing research there.
Sounds wonderful. I'm very curious with regards to, was there any particular moment or client or just question early on in your journey that sparked your interest in OCD?
That's a good question. I can't pinpoint a specific person. I think I found it a very fascinating and complicated disorder, and um, trying to think of the function of why people have rituals. The model back then was a very simple model of OCD. The idea was that it's something very akin to addiction, and
Mm-hmm.
people have anxiety. They want to reduce the anxiety by doing the rituals. They do the rituals, anxiety comes down, that reinforces the behavior, and they do rituals again. So it is a very, very similar to drug addiction. Um, Today, I think it's a very, very simplistic kind of model. It
Mm-hmm.
doesn't explain a lot of what we know about OCD today. But I thought it was, it's also a matter of temperament, probably. I find it difficult to work with depression because something about the slowness and the negativity and the passivity doesn't connect with me. Where
Mm-hmm.
LCD is all about action and doing things and trying to
Okay.
change things. And so I think I felt myself more comfortable there. But I can't say there was a specific client, probably an accumulation of meeting several people
Mm-hmm.
and trying to understand the disorder and what leads them
Mm-hmm.
to do their rituals and what kinds of obsessions they have.
Yeah.
Um, yeah.
Amazing. And for those who are just beginning to recognize their own OCD symptoms,
Mhm.
how do you personally understand or explain OCD in simple terms? I think you've just alluded that it is quite complex. So how could we try and explain it a little bit?
So I think, in terms of defining it, I think the DSM definition, people have usually both obsessions and compulsions, where the obsessions are these intrusive, repetitive thoughts that cause distress and lead people to do rituals, either behavioral or mental or both, in an attempt to reduce the anxiety. I think the description is correct. I think the mechanism is what we're trying to understand more about, but I think the definition is usually correct. Um, and there's a variety of symptoms, but many symptoms center around checking or washing. That's the most common ones.
Yeah.
Um, Two, Meryl,
Hi
your
there.
video froze for a while, and I think
I
I
believe
see that you
so.
have some communication maybe
Am I
problems.
back? Am I back?
You're back. You're back.
I
You're back with
apologize for
us.
that. I'm not sure what
No, no.
happened there.
Okay. Okay, we'll see if it happens again. Hopefully
Okay.
not. I know it didn't really happen to you. Um, so yeah, so I think generally definition is relatively simple, even though the disorder is complicated. But I
Mhm.
think diagnosing OCD is not that difficult.
Okay. Um, I know this wasn't part of our prescribed questions that we sort of went through earlier before this
Don't worry about it.
session.
I don't remember what it was.
I'm
So,
I'm really curious, and I think others may as well. Where does OCD come from? Is it the chicken? What comes first, the chicken or the egg? So does the compulsion come first, or the action to try and then relieve? Where does it come from, and what normally starts first?
so I think we've know it. It's first of all, I think there's no one way. I did interview several people with OCD and asked them about whether they recall how the OCD started. And some of them had stories that made very good sense of sequential things. Like somebody said he was, for example, washing the dishes when he heard something about some kind of cancer, and he was afraid that his grandfather would have that cancer, and he had this idea that if he just washed the dishes well enough, then his father maybe
Mm-hmm.
wouldn't get the cancer. So,
Yeah, yeah.
that's some stories. Other stories are that people probably started actually more like compulsions, that they were something very disgusting happened, like I don't know, the sewer came up in their house, and they
Mm-hmm.
started cleaning it, and then they began to feel that they didn't clean it well enough, and
Mm-hmm.
that this contamination spreads around the house.
Yeah.
And then they developed all kinds of avoidance and rituals in order to not be contaminated or combat that contamination when it occurred. So I think there's no one history, no one story.
Yeah.
Um, and sometimes I think that, people invent the story to justify some kind of feeling that they have. Okay, so
Mm-hmm.
they have some anxiety that they don't understand, or they have feelings of dissociation, and they say that it must be because some problem with I don't know, time space has occurred, and then that what explains it. So I think there are many, many ways to develop
Mm.
the syndrome of OCD.
Is it important for the clinician or the mental health professional to understand and know where these come from or what the cause may be? Is that important in the journey?
Usually not. Usually
Hmm.
not. And I think also because I don't think that the story people build themselves is a real history of what happened. It's more like a narrative that they have. I
Yeah.
think that's true in general often. Then I think that no, they usually would be a waste of time to get
Mm.
into the history,
Hmm.
and it would be much more fruitful to get into the present and see how to resolve the
Yeah.
problem.
Okay. Absolutely makes sense. And in your experience, what do people often get wrong about OCD, either in the public conversation or even with clinical settings?
So, in the public opinion, I think people talk about OCD like, I'm a very precise person and
Hmm.
I like things to be organized and I clean the house a
Hmm.
lot and I like the
Hmm.
things to be in order. But
Hmm.
when it comes like without anxiety and without often all these magical beliefs, then it's not really OCD. So it's almost like when people say, "Oh, you're autistic," and they mean,
Mm.
person doesn't understand things. So I think it's really often misused in
Yeah.
that way. In the clinical settings, it depends. I think now there's much more awareness of what OCD is. I think in the past, 20, 30 years ago, often people got confused between OCD and schizophrenia or psychosis. And
Mhm.
I see my students also when they are in the beginning of their training and they encounter people with OCD and they think that because the obsessions are so bizarre, that must mean that it's like a psychosis, and it's really
Yeah.
not. People with OCD don't really believe that their obsessions are true. They just are not sure that they're not true.
Hmm.
And that's
Hmm.
a big difference, right? I mean, there's the
Absolutely.
doubts, and so I think it's easy to differentiate, even though there are some people who have both. But
Hmm.
uh, but I think it's OCD is clear. I think if you know OCD, then it's not that difficult to diagnose correctly.
Yeah. I recently read a paper from IOCDF, if I'm not mistaken, and it
Mhm.
reported that uh, um, I'm paraphrasing, I'm not getting the statistic obviously correctly, because I don't have it in front of me, but it was around 90% of individuals who have OCD do not get treatment. Um,
90%?
I think it was around 90%.
That's very sad if that's the case.
Absolutely. And do you have maybe a thought as to why that might be? Why is such a large, even if we just take 90% away, it's a
Mhm.
large amount of people. Why is
Yeah.
such a large amount of people, in your opinion, who are experiencing OCD symptoms, who may have been diagnosed with OCD, are not getting treatment?
That's a good question. I think if we talk about behavioral therapy or CBT, which is the most efficient non-pharmacological treatment for OCD, I think there are probably not enough people who are trained. I think in the
Mm,
public health system, which is sometimes whatever, the only thing people can afford, there are very
mm,
few trained people. So at least in Israel, and I think it's the case in many other places, people are forced to go to private clinics to find the
yeah,
experts, and that's
yeah.
expensive and it's difficult to get. Um, there are many efforts to train more and more people in the system, in the public system, to be able to treat OCD, but it's only beginning. So I think that's one deterrent.
Mm,
In terms of pharmacological treatment, I'm not so sure because it's usually available. If you're thinking about psychological deterrents, I mean, why people don't even try to get help, that could be, shame, feeling that they're crazy
mm,
and that they don't want people to know. And maybe if they approach treatment or seek treatment, then somehow it would hurt their personal relationships, work relationship, and so on. Um, I don't really know, but there are many, I
mm,
can see
mm,
many possible deterrents.
mm.
I think the shame is certainly less than it used to be because there's a lot of understanding of what's going on. There are these OCD
Yeah,
forums and
yeah,
Facebooks and all social
yeah,
media. And
yeah.
so people are much more aware of what OCD is and they feel they're not
Mm,
alone in it.
mm,
So I think I'm hoping that it's improving now.
I think I would agree with you, and especially what you were mentioning earlier about the misconceptions of OCD.
Hmm.
I hear it all the time. I was
Hmm.
even just at a university the other day doing an assessment, and I was just putting my stationery on the table, and I was just aligning it like nice and neatly. And a comment came from another student, "Oh, you're so OCD, obviously."
Yeah.
I looked at them and I was like, "Ugh, okay." So I think what's really
Yeah.
interesting is that the stigma has, I think, reduced
Hmm.
because there is a lot of misconception about OCD. Everyone's
Yeah.
OCD. And that kind of
Yeah.
reduces a little bit the shame and the stigma because it feels very normal that we all a little bit OCD in some way. That's the misconception.
Yeah. Maybe
So
maybe
I
that's
would
part of it.
agree. Yeah,
Hmm.
yeah, very
Hmm.
interesting. Um, I'm very interested to hear your thoughts about this. So we spoke a little bit about schizophrenia, but OCD often overlaps with many other conditions. And many people with OCD also experience anxiety, depression, body focused repetitive behaviors like skin picking and hair pulling. And in the DSM-5, these are grouped under obsessive, compulsive, and related disorders. That can be very confusing for some.
I know.
How do you understand these overlaps, and what are the most important similarities and differences that people should know?
So just a few words on anxiety and depression. I think anxiety clearly is a big part of what people experience when they have OCD. So
Mm-hmm.
anxiety about, being contaminated, both harming some other people, whatever, all these cause a lot of anxiety, and I think it's a very common symptom. And in the past, indeed, OCD was diagnosed within the anxiety disorders.
Yeah, yeah.
Depression often comes as a secondary condition. So people are, you know, very frustrated with being unable to overcome their OCD. They lose their ability to work or to be in a family, and that
Mm,
can cause depression and helplessness and hopelessness. And
yeah,
usually the depression comes after some time
yeah.
with the OCD, secondary depression. I didn't follow the statistics about exactly the overlap between body-focused repetitive behaviors and OCD.
Mm,
In my experience, it's not that common that people have both.
mm,
It's true. I mean, some conditions are very commonly associated with OCD, like anorexia, but there are
yeah.
many fewer people with anorexia. It's a much more rare disorder. So
Mm, mm,
most people with OCD will not have anorexia, but many people with anorexia will have OCD. I think the bodily BFRBs are much more behavioral. I think they're often designed to release anxiety or stress, and they're sort of
mm-hmm,
comforting behavior.
mm-hmm. Yeah.
There usually aren't so many obsessions in these disorders. Often they're done unconsciously and it's less ritualized often.
Mm-hmm,
Um, and I think generally the more behavioral approaches are more effective for BFRBs. And with
mm,
OCD, sometimes it's more complex. Sometimes you need also the cognitive part, the metacognitive part. Um, it's a much more complicated disorder, OCD, because it involves
mm-hmm.
all these different aspects. Whereas, really, we can think of BFRBs as something behavioral, habitual, almost automatic. And many people have different levels of that. And it's only when it becomes, people like chew their fingernails until it hurts, or they
Yeah,
have baldness in their hair, or
yeah,
they
yeah,
injure their skin in a very bad way, that they go to therapy, But
yeah.
I think for me, it's a little different category. So I'm
Mm-hmm.
not sure I agree that it's like one bunch of disorders.
Yeah, I think that kind of leads to then my next question. You mentioned that previously OCD was listed as an anxiety disorder. Now it's its own thing, and it has then a subsection, OCD related disorders. Do you foresee in the future that the DSM is going to change yet again? And do you
I don't know.
agree?
It
Yeah.
could. I mean, it could. I
Yeah.
mean, the way it works is not like we have these new incredible discoveries that lead to the changes, and
Yeah.
it's committees basically. I
Yeah.
hope I'm not insulting anyone, but people sit
Mm-hmm.
together and they
Mm-hmm.
decide that maybe it would be better to put it there. It's not like we have very strong, I don't know, scientific genetic evidence that it's related. Um, and it's a matter of convenience. So what would, how would it be better for us to approach BFRBs as a kind of OCD, or would it be
Mm-hmm.
better for us to approach OCD as a kind of a, BFRB, or maybe an anxiety disorder? There are clearly elements in the treatment of OCD that are more similar to anxiety, for example, the exposure part,
Mm-hmm.
which is very similar in anxiety disorders and phobias and so on in OCD. So I'm not clear that it's a better match,
Mm.
but it's just my own opinion.
Yeah. And when it comes to the real world care, what do you think clinicians and people seeking help most often miss or misunderstand about these co-occurring or related conditions, particularly
Hmm.
around diagnosis and treatment? I think you
Hmm.
kind of already shared
Yeah.
some thoughts around that.
Um, I don't know if people make a lot of mistakes about the diagnosis, because diagnosis, again,
Mm,
OCD is clear what it is. I don't think
mm,
people will confuse between a BFRB and OCD. The criteria are different, right? Here
yeah,
is behaviors that people do that cause some usually physical damage. With
yeah.
OCD, you have this obsessional part, you have the rituals, you have the magical thinking, which is completely absent
Hmm.
in behavioral addictions or in BFRBs. So I don't know. I think people need to know how to approach and treat each one of these problems. But I think the BFRBs are more similar to each other than they are to OCD.
Hmm.
So,
Um,
if you can treat hair pulling, you can probably treat skin picking, uh, nail biting,
yeah,
and other kinds of behaviors like that. And you
yeah.
use things like habit reversal techniques, which are not so much relevant to OCD.
Hmm. Yeah, exactly. Your work has challenged some traditional ideas about OCD. How has your own understanding of OCD sort of changed over the course of your career? And what are some of those ideas that you have about OCD that are a little bit
So
different
I
that you'd
think
like to
most
share?
of Yeah, I think most ideas came from my clinic. I think that I observe certain things in my client that I think are not really described as part of OCD, and maybe we're missing something very important. And I think it started from the emphasis on doubt, on this phenomenon that people with OCD have this uncertainty. They don't trust their memory, they don't trust their perception, they don't trust their judgment. And I think gradually I wanted to clarify to myself exactly what this doubt is, what it focuses on,
Mm-hmm.
what causes it, why it's maintained, and why does it's not resolved. Um, and so gradually, with my colleague Neil Lieberman and my ex-student Amit Lazarov, who is now a colleague at our department, we began to develop this theory that we call the seeking proxies for internal states, or
Mm-hmm.
SPIS, as we like to call it.
Mm-hmm.
And the main idea there is that we can understand many symptoms of OCD as reflecting difficulty in accessing someone's internal state and trying to compensate for that by using various what we call proxies to infer your own internal states from this objective evidence. So, for example, if I don't know, I mean, we use this example a lot in our articles, in our papers. If I don't know how much I like my girlfriend, I can see how many text messages I sent her, or I can see how much money I
Mm-hmm.
spend on presents for her.
Mm-hmm. Yeah.
If I don't know how hungry I am right now, I can, I don't know, examine how much time has been since I last ate. I can develop like precedents, like, habits that will. So the idea is that people try to find ways in which will free them from relying on their own internal states, because looking inside, reflecting on the internal states is difficult for people with OCD.
Mm-hmm.
We have many studies that support this notion, and we saw, for example, that people with OCD are less good in estimating things, even like their muscle tension, their relaxation level, their level of hunger and thirst, their emotional response to things. Because when they try to reflect on these things, they get into trouble. They don't get clear messages from their inside.
Mm-hmm.
Uh, and so what they do is they develop rules and they develop procedures that would help them decide for them or infer their internal states, right? So if I don't know how hungry I am, I can see whether my shirt is tight on my belly. And if it's tight,
Mm-hmm.
it means I've eaten enough. And if it's loose, then maybe I haven't eaten enough. So we think that's a very common way to think about that. That's a very convincing, compelling way to think about OCD.
Mm-hmm.
And that is a
Um,
new model of OCD. It's a new understanding.
so the examples that you've given, the eating and the
Relationship maybe.
yes,
Mhm,
yes, yes. I
mhm.
can get that. That's very practical and fantastic examples. How would you then take that sort of idea and apply it then to OCD? How would that really work
You
for those
mean
who are
how
listening
I,
and trying to understand the process?
so you mean that what I described is not typical OCD symptoms, you mean?
No, no,
So,
I think.
no,
Oh, no, go ahead. Go ahead.
no. What was your question then? How I would use it to treat people with OCD or?
Yes. How would you
Oh,
use that sort of that mindset then, or that those examples in
hmm.
a practical sort of OCD scenario?
Okay, so in my clinic, I think oftentimes when I think it's relevant, like for example, in our OCD, right? And people who have
Mm-hmm.
difficulty in OCD in relationships, they don't know if this person is right for me. They don't know if they feel what they're supposed to be feeling towards a certain person, the person they're with.
Yeah.
Um, I think there's those very, to me, clear examples of being unable to access your internal states, your feelings, your
Mm-hmm.
attraction, your
Mm-hmm.
um, and then they try to infer whether the relationship is good and whether that person is good for them by looking at their behavior, for example. And like I
Mm-hmm.
don't know, like are they buying me gifts? Did they remember that I don't like vanilla ice cream? I mean, it's things like that
Mm-hmm.
are sort of
Mm-hmm.
objective, and I can try
Yeah.
to infer from those. So I explain that this process to my patients, and what I say to them is that it's very unuseful to rely on proxies because the proxies are not the internal state. They're not the same thing.
Mm-hmm.
When you more and more rely on these kinds of proxies, you more and more lose your connection to your internal states. And you become more removed from them, and you lose the
Mm-hmm.
ability to really connect to what is really true for you.
Yeah.
So that's an example from I think even hand washing. I mean, when you think of hand washing, then, hand washing is a problem because we don't have clear criteria to when we're supposed to stop. I
Mm.
mean, how do you know that you've washed enough?
Mm-hmm.
I mean, you don't count germs because you don't see them.
Yeah.
You can see, I mean, so what do people, everybody does, I say we develop some routine, right, to
Mm.
do that. And then we wait for some kind of internal signal that tells us we've washed enough, right? We've
Mm.
done enough and we can go on. But if you don't have clear signals from inside to tell you to stop, there really is no other way. And then you begin to develop rituals and say, if I did my ritual, that means my hands are clean even if I don't
Mm.
get any good signal from my hands or from my body or from my
Mm-hmm.
sense of satisfaction that I've done enough. So I explain the model to the patients. I think many of them find it very relevant,
Mm-hmm.
and it provides them some clarity about why they do what they do.
Absolutely.
In terms of finding ways to correct that, I mean, from our model, you would infer that if there's a big problem in accessing internal states, and if we can understand many OCD symptoms as ways to try to compensate for that, then it makes sense that if we help people to connect to their internal states and read them more clearly, then we could improve OCD symptoms this way. So it could be something additional to the regular kind of therapy that people do with OCD, which is mostly response prevention, and exposure, some cognitive therapy, there are many other modalities. But this could be an extra modality. And we are now doing some research to try to find out what are means that we can use to help people connect to their internal states. One major one probably would be mindfulness training. So if you train people to be mindful to their internal
Mm.
states and
Mhm.
try to listen to them in a quiet, non-judgmental way,
Yeah.
that probably does help. We already have a couple of studies show that it really does help to improve
Mm.
OCD symptoms and to make, take OCD. For example, we have one study now, I'm just writing it on my other screen here, where we use the procedure that we have a procedure that we show that people with high OCD tendencies, not just people with OCD clinical, um, are not very good in knowing their muscle tension. I don't need to get into the procedure, but they,
Yeah.
they're, they're, they don't judge their muscle tension very well.
Mm.
And we
Mm.
showed that even with 10-minute mindfulness instructions, it improves their
Mm.
performance on this task. We have
Yeah.
another study where we have real mindfulness, like groups that go on for several meetings. And they
Mm.
also reduce OCD symptoms very strongly. So I think that would be one way to improve. We have some other ideas which are a little less cooked, I would say, right now. But
Mhm.
I think that's a
Mhm.
very, very big question that we're trying to answer.
Mm.
And in most of our work so far has been really to support the model, to do many, many kind of experimental studies,
Mm.
develop questionnaires and so on, to show that this problem really does explain a lot of OCD and has to do with OCD. But the question now that rests to our door is how to use that knowledge that we have, that theory, to help people with OCD.
I wonder if you've already answered my question now.
Uh-huh.
But I'm curious then, because you are one of the main things that you're currently doing is research. So, what
Uh-huh.
are the current research questions or clinical directions related to OCD are you most excited about right now? Whether you're the one writing the research or you are looking at a distance from your peers, but what is really interesting to you right now when it comes to research around OCD?
So I think some of it continues to be questions that have to be with our model, that many questions that we
Mm.
don't really know the answers to. And some of it, as I said, is trying to explore ways to resolve the problem and help people to still connect with their internal states. Um, I don't want to get into some of it is very technical, so I won't get into
Mm.
it.
Mm.
But there are many big questions that we don't really address, but I would love to know more about them. For
Mm-hmm.
example, so if we say these people with OCD have problems accessing the internal states, we don't know if that was before they
Mm.
had the OCD, or
Mm.
it's just part of the OCD. So
Yeah.
if I begin to have doubts about my internal states, I ask questions. Do I like my girlfriend? Did I wash
Mm.
my hands enough? Am I really religious sufficiently?
Mm. Mm.
Uh, do I really care about my mom? Things that are typical to people with OCD.
Yeah.
Uh, then that might begin the process of getting far from your internal states, beginning to use proxies, and that's what starts this whole cycle going. We don't know if that's the case, or maybe there was a problem to begin with in accessing
Mm.
internal states,
Mm.
so that people
Mm.
who have difficulties accessing their internal states are vulnerable to developing OCD later. That's one
Yeah.
question we don't know how to answer. Another interesting question is, how does access to internal states develop normally, right?
Mm-hmm.
So how does a child learn that something is anger and something else is distress and something else is pride and something else is shame?
Yeah.
Uh, they probably learn it by being reflected by their parents. So the parent,
Mm-hmm.
they come home and they say, "Oh, I got an A," and their parent says, "Oh, you must feel proud," right? So that
Mm.
they
Mm.
learn to somehow connect whatever they're feeling now, this mess of feelings, they learn to label it pride, and they will be able to recognize it later. And we can ask what may go wrong in this process. Why do some people, and it's not only people with OCD, but they don't want to go too far from OCD, but even people with autistic spectrum problems, what goes wrong in their ability to recognize what they're feeling? Okay, so that's the big question we would like to be able to answer. Uh, Other things that I think I'm very curious about is, for example, we take our OCD,
Mhm.
relationship-centered OCD, where people have doubts about their relationships. It seems something fairly new in the
Mm.
society.
Mm.
And I'm wondering what kinds of things that happen now in society
Mm.
trigger these kinds of
Mhm.
insecurities or fears. Is it like perfectionism about relationship? Is it something that our expectations about relationship have changed? Is it something about that we really care about what other people think of who we're with, and that sort of triggers our anxiety, and so on. So I think those are really interesting questions as well.
Mm.
I think like dating apps make things much worse when it comes to our
Mm.
OCD. So, there are many, many things to ask,
Yeah,
more than to answer, more than
true,
answers of
true.
questions, for sure. Yeah.
You've mentioned ROCD a couple times in this session.
Mhm.
Is that a particular interest of yours?
I think so. I think it's an interest because it's one of the places where you really see doubt in the most clear fashion. I mean, they come and say, do I really like this person? Should we be
Mm.
together? How do
Mm.
I understand why he did that? And am I attracted to them? Usually I'm not attracted to this kind of person. Why am I
Mm.
attracted? Am
Mm.
I attracted? Maybe there's another person that might be better for me, which, by the way, I always answer, there definitely is, because
Yeah,
statistically speaking,
yeah.
there must be somebody out there who's better for you. Uh, but all these doubts, are very central, and I think that's what attracted me to OCD to begin with is this idea of
Mm.
doubt, and what
Mm.
is it that why can't you just know?
Mm.
So I think that's why OCD is interesting, and also because it is a new kind of disorder, because I see very clearly how the society affects it, and social media, and maybe sort of the narcissistic age has
Mhm.
to do with it. So it's just, but I don't treat it a lot. I mean, I treat all kinds of people, not just
Yeah,
people with ROCD, but I find it very interesting and useful for me to think about it. And
yeah.
yeah.
So for those who are not really sure what we're talking about,
Mhm.
there's OCD, and then there are many subtypes to OCD. If you
Right.
can maybe just explain a little bit about that for those who are just coming into the OCD
Sure.
world and just being like,
Sure.
what are subtypes? Why are there subtypes? And are there new subtypes coming up on a regular basis? And is there any other new subtype that's about to show its face?
That's a very good
I think,
question. I don't know if I can answer all of them, but when
yeah,
I
sure.
was started working with OCD, that was probably 1982 or something like that. It was
Wow.
quite a few
Okay.
years ago. Yeah, when I
Okay.
was a doctoral student in Wisconsin.
Amazing.
People talked about washers and checkers.
Mm,
Those were the two
mm,
categories. People who
yeah.
wash, and the differences between them, and people believed there were really separate groups of people. So
Mm,
people who
mhm,
wash are people who are concerned usually about contamination, about their own safety or health.
mm,
And people who check are people who are more worried about harming other people, and they're more obsessive, and they have
mm,
more like checking kinds of symptoms.
mm,
And as far as I remember, some people talk about pure obsessionals, but there
mhm,
was a big discussion whether they exist or not. And that really developed over the years, in many ways. And so today, I think I'm not sure what the official subtypes are, but some they could talk about. There was religious obsessions. There's
mhm,
um, you know people who are more or less engaged in magical thinking. People who are more obsessive versus more compulsive. People who are only compulsive and don't have any obsessions behind their compulsions that also exist. And again, new things like ROCD. But if you go into OCD forms, they keep
Mm.
coming up with new types of
Mm-hmm.
OCD.
Mm-hmm.
So, for example, we have one study now that we talk about, which is, and that has to do with a subtype that's called hit and run OCD. And what's hit and
Mm-hmm.
run OCD is people who worry that maybe while driving they might have hit someone,
Yeah.
and then they go in circles checking the road again to see if there are any
Yeah.
dead bodies beside the road, and maybe they would call hospitals to find out if there are any reports of hit and run accidents, and so on and
Yeah.
so forth. It's a major checking kind of OCD. So that's now a new type of OCD. Um, and each one of these things really raises to me very interesting questions, because if I always think, how do people without OCD know that they didn't run over someone when
Mm.
they drove?
Mm.
How do we know?
Mm.
And I think the only way logically that we can know that is if we can say to ourselves, if I would have hit someone, I would have known it. I would have noticed it. I would have remembered it. There's no way that I could have run over someone and not notice it.
Yeah.
But if you don't have that trust in your memory and perception, then you can see how, I mean, there's no way of knowing for sure,
Mm.
right?
Mm.
Because you can't know things that didn't happen. You can
Yeah.
only know things that did happen. If I
Yeah.
did run over someone, there's clear input from my senses that I hit someone.
Mm.
But if I
Mm.
didn't, there's no information. I can only infer that if I would have hit someone. So all these questions, they keep coming up, and they keep, trying to understand this phenomenon, and
Mm.
but side typing, if you look at even questionnaires like the OCIR, which is now it's 30 years old probably, or nearly so. So there is obsessions, there's compulsions, there is neutralizing, there's hoarding, which now was also taken out of OCD.
Mm-hmm.
So these the classic subtypes, ordering, um,
Yeah.
but I think these are more like groups of symptoms than they are
Mm-hmm.
typing types.
Okay.
But I know this area is there are a lot of discussions about whether it makes sense to think of types. Is our OCD, or is our OCD something completely different than OCD? So all these things I think are being discussed, and I don't think there's a clear answer.
Mm.
And
I
like the decision about hoarding was a decision also that some committee decided that's not really OCD. I don't
mm.
know. I think there are some similarities and many differences. Um, yeah,
I think
I
just
think the
to your
main thing
point
is,
that there's so many
sorry.
questions. No,
Yeah,
no.
yeah.
I was just saying there are so many questions. I think there's an indefinite amount of ideas to write on research because there's just so much to think about.
Hmm. I agree. And it's to me fascinating and important, a fascinating disorder in the sense that that these are people like you and I. They Many of them, those that I see in my clinic, can be very successful
Mm-hmm.
people, and they're stuck in these kinds of ideas and behaviors that seem completely dissociated from who they are.
Yeah.
And that makes it very tragic in some way, interesting in other ways,
Mm-hmm.
problem, and I'm glad I ran into it by chance.
We are
Yeah.
glad that you ran into
Yeah.
it.
Thank you. Uh,
We're getting close towards the end of the session. So I have one question left for you, but I'm going to leave it right until the end. Is
okay,
there
let me I'm
anything?
just 1 second, sorry, Mel.
No problem.
Just opening the window because the door is closed here, so it's a little tense. Yeah, go ahead, sorry.
No problem. Um, is there anything that we have not discussed in this session? Obviously, we for anyone who's watching right now, we plan on having Professor Reuven many more times. But
Okay.
is there anything that we have not discussed here that you really think that you want to just quickly touch on and just talk about quickly?
Um, as you said, there's so many things. I'm not sure there's one particular thing that I think is missing, but if we
Mm,
have more chances, we can focus on other things in the future. So if
absolutely.
people have questions, I'm happy to address them
Okay,
and give them a chance to.
amazing.
Are there
So
questions?
So then my last question for you then is
Okay.
if listeners take one thing away from today's conversation, especially those just struggling or feeling a bit confused about their symptoms, what would you hope that would be? That they could take away just one thing from what you've said today?
Um, Good question. I think my advice would certainly be go to people. If you need help, go to people who specialize in OCD.
Mm-hmm. Mm-hmm.
I think that's a critical error that people sometimes make. They go to a therapist, which might be fine, general therapists, psychodynamic therapists, or even people who do CBT, but don't have a good experience or sufficient experience with OCD. I
Mm-hmm.
think OCD is different enough that it's really recommended to go to somebody who specializes. That would be maybe my main advice. It's not exactly takeaway from the session, but it's
Yeah, sure.
something to keep in mind.
No,
Yeah.
absolutely. And I think everyone who is here, we can certainly be reassuring that, Stop OCD is an online program that
Hmm.
specifically addresses and specializes in the
That's
treatment of
right.
OCD.
That's right.
So if you're curious, this is
Yeah.
definitely the place.
Yeah. Yeah.
If those who are watching right now, if you have any questions for myself or certainly Professor Reuven Dar, please write them in the chat box. There's currently no questions just yet. I'll just give
Okay.
everyone a minute or two just to maybe uh, start typing them. I do see that there is a hand raised. Just
Hmm.
due to confidentiality reasons, I won't be able to sort of let you speak, but you're welcome to let me know anything in the chat box if you want to
Hmm.
raise anything.
I don't see the chat box on my screen, right? Is that because I'm the
It's a
host?
Q&A. It
Or...
says Q&A.
Oh,
You should be able
Q&A.
to.
Okay, Q&A.
Yes,
Yeah, I see
yes,
that.
yes,
Okay, okay, okay.
yes.
Mhm.
Um, Otherwise, as well, as I mentioned, this is recorded, so there will be a recording. So if you have any questions, you can post them underneath the recording on our YouTube page. There is a question here. Why do we plan to add more to the rituals, and how do we help them take away from their ritual?
I'm not sure I understand, but let me just to
Yeah.
clarify, maybe that person means that why do rituals become more and more complicated? Like, why do
Mhm.
they get larger? Is that the question?
Yes.
Yes,
They've
okay.
responded yes. Yeah.
So I have a theory about that. I just lost the Zoom just a second. Sorry. Yeah, so I have a theory about that. I don't know if it's true, but I'm going to put this question on the side here so I can see it. So I think the reason is this, that when people do their rituals, it's very,
Mm,
very important for them to be in control of what they do. So if I have a ritual of washing my hands, I want to make sure that I do it correctly, right? And that I'm focused all the time on anything that I do. Once a ritual, if I do the same ritual over and over again, it inevitably will become automatic.
mm,
Once it becomes automatic, then I can't focus on it like I used to
mm,
because I just
mm,
do it without noticing. And that doesn't
mm,
feel right for people with
mm,
OCD. So the only way to get it back under control and make it
mm,
de-automatized
mhm,
is to increase it, make it more complex, add another step, and so on. And that
mm,
would take it out of the automatic mode and put it
mm.
back under my conscious volition. So I have a
Yeah.
sense of controlling my acts. And I think that's the reason. Nobody has evidence for it. I mean, I've interviewed
Mm,
many people and they seem to connect with that idea, but it
mhm.
hasn't really been studied systematically. But it's a really, really good question.
It is, and I think your explanation is very valid. And it's
Hmm.
so surprising how then that hasn't been further developed and
Hmm.
researched and
Right,
understood.
right.
There's another question here. Is chronically treatment resistant OCD with having undergone cap,
Capsulostomy.
cap, thank you, having
Capsulotomy.
any,
It's a brain surgery. Yeah.
having any more chances of treatment. I have also undergone deep TMS, but I cannot get over my washing with antiseptic Dettol. Is my OCD turned to addiction?
Oh, that's a difficult question to answer. It sounds like she did. This person had a lot of treatments, and if she had capsulotomy, that means people get accepted into this very extreme kind of treatment if they had many kinds of attempts on more regular treatments before. So that's why she feels, or he feels, no, she feels that she's chronically resistant. I'm not sure that understanding it as addiction makes it is a helpful. I mean, it's informative. If we call it addiction, does that help us? I'm not sure because people with addiction can get help. So I don't think that when we understand it's an addiction, that explains why it's so resistant to treatment in this person's case. And I don't know what the other options are for people who had all these kinds of treatments, except maybe, going finding a new therapist. I always think that the best approach is always the cognitive behavioral one by experts because it has it's more time. I mean, it stands the test of time. If people take medications, when they stop, usually the symptoms return. But people who go into CBT learn things, and the results of long-term trials with OCD and CBT are very good. So the only thing I would advise is seeking further help and not thinking that an addiction, calling it an addiction, means that now life is over and I can't fix it anymore.
Yeah. Absolutely. Thank you for that. I hope that answers your question. Yes, and she says, thank you so much. Great. If there are any other questions, you can send them through. We have a couple minutes left. I think I've really and thoroughly enjoyed this session. I will definitely be emailing you very soon to arrange another session for this year. Certainly a few more if you have the time. Not only myself, but I think others have also enjoyed this. Your knowledge is really, you've been doing this for a very long time.
Yes, I have.
I won't give away my age or yours, but you were doing it before I was even born. So it's just
Yeah.
phenomenal.
Right.
Yeah, so thank you so much. If there's no other questions, I'm going to let then everyone then get on with the rest of their day a little bit earlier than expected. Professor Reuven, just thank you so very much. This has been
You're
an
very
excellent
welcome.
session for me and I'm sure for everybody else. And yeah, wish you all the best with
Thank you.
the research that's cooking and the ones that are not yet. We really look forward to reading some more information that comes from you and your team.
Okay, I'll be glad to present it, and we can even think of maybe one session dedicated particularly to the model of OCD that we developed, and we
Absolutely
can go over it a little more slowly and give you more time to understand it.
There's one extra comment I'd love to share with yourself and the rest. Sure do appreciate how you both are reaching out to help people who are challenged with this disorder. And another comment, thank you so much. This is why we're doing this. This is why we're making it free. So we can just share information. There's no point in having you spending hours creating research and it's not shared with the public. And we want to make sure that's easily accessible to everybody, and obviously the treatment. So thank you so much. And if anyone is interested in the program, please, you're welcome to email us if you have any questions. We are running promotions all the time. There currently is a very good promotion at this moment. You can also use a promo code webinar100 to get $100 off your first month. But if you have any questions, you need any other further support, you can email us at support@stopocd.com and we'll be there to help you. Thanks so much, everybody. Thanks, Professor Reuven. It was wonderful to chat to you.
I'm glad that I hope it was helpful to people, and I'll be glad to talk to you.
Absolutely. Wonderful. Thanks, everyone. Have a wonderful rest of your evening and day. We'll
Thank you.
chat soon.
Bye bye.
Bye.